Welcome. Today we're really getting into some critical details about how emergency responders handle behavioral health emergencies. We're looking at specialized instructional material, the kind EMTs use.
Yeah, and it's a topic, that's often misunderstood, how emergency services actually approach these mental health crises.
Mm.
Well, it's not always what people think. This material gives us some real clarity.
Right. So our goal here is to pull at the key definitions, the safety rules, the management techniques. We want you to understand the critical distinctions and, frankly, the risks involved in these really high-stress situations.
Exactly. Knowing the difference between someone having a really bad day and someone facing a true medical emergency is, well, it's vital.
Okay, let's tackle a big assumption right off the bat. A lot of people think if someone's in crisis, they must have some long-term mental illness. What does the training material actually say?
Well, that's a major misconception. The sources really hit hard. They stress that perfectly healthy people can have acute, temporary mental health episodes, usually triggered by intense stress.
Like what kind of stress?
Think about, the immediate aftermath of a really bad accident or a sudden divorce, maybe a death in the family. The key thing for responders isn't just the feeling itself, it's how long it lasts.
Ah, okay. So normal sadness is one thing.
Right. But it becomes a real behavioral health issue when those feelings, that inability to function, just go on week after week. That persistence is the signal.
Got it. And the other big myth, the one about danger, that people in crisis are always violent.
Yeah, that's a huge distortion. Statistically, only a small percentage are actually violent. But, and this is critical, EMTs face a selection bias.
Meaning they only get called when things are bad.
Exactly. They're called because family or bystanders can't manage it anymore. So by the time responders arrive, they are seeing the situation at its absolute peak risk. It's not the typical experience, it's the crisis point.
Okay, so let's clarify the terms they use, because it sounds like there are different levels of concern.
There are. It starts simple. Behavior. That's just observable actions. What someone does in response to their environment. Pretty straightforward.
Okay.
Then you step up to a behavioral crisis. This is a reaction that actually interferes with daily life. Or maybe it's unacceptable to the patient, their family, the community.
Like hoarding, maybe. Or chronic depression that stops someone from taking care of themselves.
Exactly. Those are good examples. It's disruptive, serious, but not necessarily an immediate, life or death threat at that moment.
And the top level, the one needing immediate action.
That's the behavioral health emergency. Now we're talking about behavior that actively threatens the patient's own safety or the safety of people around them.
So like a suicide attempt. Or someone completely agitated and out of control.
Precisely. Or bizarre behavior that puts them or others in harm's way right then and there. And it's worth remembering, these aren't rare. Mental disorders affect tens of millions in the U.S. every year. Anxiety disorders, for instance, are incredibly common.
Okay, this next point feels absolutely critical. The training says even if someone seems clearly delusional, EMTs have to look for physical causes first. Why is that so rigid? Why assume physical?
Because a physical problem can look exactly like a psychiatric one. And if you treat the behavior but miss the underlying physical cause, well, the patient could die. It's that serious. This is where the two basic categories come in. First is organic brain syndrome.
Organic meaning physical, right? Something wrong with the brain tissue or body chemistry.
Exactly. Temporary or permanent brain dysfunction caused by something physical you can measure, like a traumatic brain injury or seizures, maybe drug or alcohol issues, withdrawal, and critically, metabolic problems.
Like low blood sugar.
Yes, hypoglycemia or hypoxia, lack of oxygen, impaired blood flow to the brain, even severe changes in body temperature, or diseases like Alzheimer's.
Wow, so someone with dangerously low blood sugar could appear completely psychotic.
They absolutely could. And that's probably the highest stakes moment in the initial assessment. The source material is really emphatic here. You never make a psychiatric diagnosis in the field until a doctor has actively ruled out all possible medical causes.
Because missing hypoglycemia.
Or hypoxia.
Yeah.
Yeah. Missing that because you assumed it was just mental illness can be a fatal mistake. It's a life threat.
Okay, so if they've ruled out those immediate physical mimics, then they consider the functional disorder category.
Correct. Functional means the body, the brain structure appears normal, no obvious injury, no measurable chemical imbalance like low sugar, but the function, how the brain is working, is impaired.
Like the software analogy you mentioned earlier.
Kind of, yeah. Think schizophrenia, clinical depression, severe anxiety conditions. The root cause isn't something you can easily point to physically in that moment, But for the EMT on scene, the rule is always stabilize any physical issue first, regardless of what you suspect the underlying cause might be.
All right, let's shift from diagnosis inside the patient's body to the actions outside. Scene safety. The training seems crystal clear. Patient care waits until the scene is safe. What are the absolute must-dos?
The absolute first step, if there's any hint of violence or weapons, is call law enforcement immediately. You just don't go in otherwise, period.
And beyond that initial check?
There are some really interesting tactical points. They're trained. Never let the patient get between you and your exit. Always know where the doors are. Even park the ambulance strategically for a fast departure if needed. It's about maintaining control of the situation and your own safety.
Makes sense. So scene secure. Now what? De-escalation begins. This sounds like it's all about talking.
It really is. Verbal skills are paramount. If someone's agitated, you need to build trust fast. That starts with nonverbals.
Like how you stand.
Exactly. Avoid that rigid confrontational posture. Don't cross your arms. Often, squatting down, maybe angled slightly away, like 45 degrees, feels much less threatening than towering over them.
And then verbally.
Use a low, calm tone of voice. Maintain good eye contact, but don't stare them down. And be direct. State clearly who you are and why you're there. We're here to help.
The goal being to calm things down enough to maybe avoid physical restraints.
That's the ideal outcome. Active listening is your best tool here. Really show interest. Let them talk. Let them tell their story if they can. It builds rapport. It can absolutely prevent the need for a physical struggle later, which is dangerous for everyone.
And the training also covers what not to do. Right?
Yeah, definitely. Big list. Never make judgmental or disparaging remarks. Don't argue with them, especially about delusions. It's pointless and just escalates things.
Don't challenge the monster under the bed, basically.
Right. And critically, never say, I understand what you're going through. It sounds empathetic, but it often comes across as patronizing and can make people really angry. Also, basic safety. No ties, no lanyards, no stethoscope hanging around your neck. Anything grabbable needs to go.
Good point. And if the patient can't really communicate clearly or they don't realize they need help?
That's when talking to family, friends, caregivers becomes absolutely essential. They're often your best source for background, medical history, what led up to this. Assessing orientation, person, place, time, event is key too. Okay, let's talk about some specific high-risk states. First, psychosis. This is basically a break with reality, right? Where the line between what's real and what's not gets blurred.
How does that usually look in the field?
It can vary, sometimes anger, sometimes deep withdrawal. You often see it in conditions like schizophrenia, which typically starts showing up, between ages 16 and 30. Delusions, hallucinations, paranoia are common.
And the management strategy you mentioned, don't argue the delusion, focus on reality.
Exactly. Stay calm, be direct, be straightforward. You can't reason someone out of a delusion. So you acknowledge their feelings maybe, but you steer the conversation toward real, tangible things. Their comfort, the immediate situation involving family they trust can also be really helpful.
Okay, now something that sounds even more immediately dangerous, physically, excited delirium. We hear about this one.
Yeah, this is a true medical emergency. It's not just behavior. The behavior itself is causing a life-threatening physical cascade.
What does it look like?
Hyperactive, irrational behavior, often vivid hallucinations, incredible agitation, maybe superhuman strength, but physically, they're crashing. High blood pressure, really high body temperature, super fast heart rate, sweating profusely, often dilated pupils.
Why is it so dangerous? You said it's killing them from the inside.
Essentially, yes. That extreme physical agitation generates heat and metabolic waste products way faster than the body can clear them. It leads to severe metabolic acidosis.
Meaning their body chemistry goes haywire.
Right. Their system gets overwhelmed with acid. This can lead to sudden cardiac arrest. It's often linked to stimulant use, like cocaine or sometimes severe alcohol withdrawal. This isn't something you can just talk down easily. It usually requires immediate medical intervention, often chemical sedation by paramedics.
A really scary situation. And then there's the risk of suicide.
Tragically common. Depression is the single biggest factor here. Responders are trained to look for warning signs.
Such as?
Obvious deep despair, maybe tearfulness, an inability to talk about the future, like they just can't see one. Sometimes they've recently gotten the means to die, bought pills, a weapon. Giving away important possessions is another red flag, having a specific plan.
And the communication here is vital too.
Absolutely crucial. The training stresses. Don't beat around the bush. Ask directly. Are you thinking about hurting yourself? Or are you considering suicide? Asking the question does not plant the idea. It opens the door for potentially life-saving help.
Okay, let's touch on specific groups that might need a different approach. Older adults, for instance.
Yeah, geriatric patients, they have a high rate of depression, often due to loss, health issues, financial stress, but their altered behavior isn't always psychiatric.
You mean it could be physical again?
Very often. Things as simple as a urinary tract infection or even severe constipation can cause confusion, agitation, aggression in older adults. It's crucial to rule those out. And of course, dementia like Alzheimer's is a common cause of behavioral changes too.
What about combat veterans? PTSD and TBI are significant issues.
Absolutely. PTSD affects a large percentage of recent veterans, up to 20% from Iraq and Afghanistan by some estimates. And their triggers can be very specific: loud noises, certain smells. The sources even mention diesel fumes sometimes.
Wow. And they might not readily admit they have PTSD or a TBI?
Right. Symptoms like confusion or memory loss from a TBI might be hidden. The approach needs care, calm, firm voice, respect personal space. That's huge. Asking about their service details like branch or rank can sometimes build rapport quickly.
And physical restraint with veterans.
Often not the best approach. Given their training and potential trauma triggers, it can escalate things dramatically. Chemical restraint, administered by paramedics, might unfortunately be the necessary and safer option for everyone involved.
Which brings us to physical restraint in general. When it is necessary, what are the rules?
The absolute rule is it's only to prevent injury to the patient or others, and it must be the least restrictive method possible. Soft restraints are preferred over things like handcuffs, unless law enforcement applies it.
And there's a specific procedure.
Ideally, yeah. The training describes using 5 people if possible. 1 for each arm, 1 for each leg, 1 person managing the head, and 1 leader coordinating. The patient should be placed supine face up, usually with 1 arm secured up by their head and the other down by their side.
And this is where that other major risk comes in: positional asphyxia.
This is the critical warning about restraints. You absolutely must never transport a patient hobbled, hogtied, or restrained face down prone. Never.
Why is face down so dangerous?
Because lying on their stomach, especially if they're exhausted from struggling, overweight, or already medically compromised, severely restricts their ability to expand their chest to breathe. They literally can't get enough air. It can lead to sudden death from respiratory failure or cardiac arrest. It's incredibly dangerous.
So monitoring after restraint is key.
Non-stop. Airway, breathing, pulse, checking circulation and nerve function in the restrained limbs all need to be assessed and documented, typically every 5 minutes.
Okay, finally, the legal side. Consent is always best, but what if the patient can't consent?
If a patient is clearly mentally incapacitated and their life or health is at immediate risk, responders can usually act under implied consent, sometimes called the emergency doctrine. Basically, the law assumes a reasonable person would consent to life-saving care.
But what if they're refusing care? Maybe they're impaired, but seem dangerous.
That's trickier. If a patient who seems competent refuses care, EMTs have limited legal power to force treatment or transport. For patients who are clearly mentally ill or drug impaired and pose a danger to themselves or others, typically law enforcement has to be involved.
Police make the decision to transport involuntarily.
Usually, yes. They place the person in protective custody, following very specific state laws and protocols, often involving something like an emergency petition. You absolutely have to know your local regulations on this.
This really paints a picture of just how complex these calls are. Responders need to be part medic, part negotiator, part safety officer, all at once.
It's true. Ruling out physical causes first, using verbal de-escalation whenever possible, and understanding those lethal risks, excited delirium, positional asphyxia, those are the absolute bedrock principles.
It's a lot to manage under pressure.
It is. And let me leave you with one last practical point from the material: documentation. Because behavioral emergencies often lack obvious physical injuries, your written report is your shield.
Be specific, you mean?
Extremely specific. Don't just summarize behavior. Quote the patient directly if you can. Writing down, patient stated, "The voices are telling me to kill people," or patient said, "Life isn't worth it anymore," provides clear, objective justification for why you took emergency actions, like restraint or initiating an involuntary hold with police. That level of detail can be crucial later on.
Excellent point. Well, thank you for walking us through this. It gives a much clearer understanding of the immense challenges and protocols involved when first responders face these crises. Always more to explore.